Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue the discussion I began last week about cirrhosis of the liver. When I left off, I was in the process of talking about how one goes about examining someone who we know has cirrhosis of the liver or who we suspect may have cirrhosis of the liver. You would obviously take a complete history from the patient. But before I even get there, I want to give you some of the stats again. Worldwide, there are 500 million people who suffer from cirrhosis of the liver. In this country, 5.5 million people suffer from cirrhosis of the liver, and 25,000 folks every year die in this country because of cirrhosis of the liver. Yeah, so you will then take the history, then you take the patient weight, vital sign, and you proceed to examine the patient. All aspects of this patient's anatomy exteriorly is very important, starting from the hair growth. You know, the patient, if it's a man, is likely to have a sparsity of hair growth. If it's a woman, she's likely to have an excess of hair growth. And the reason for that is because all men have a small quantity of estrogens in their body, and all women have a small quantity of testosterone in their body. So when the liver is sick, the liver is not capable of getting rid of, breaking down, process that little bit of estrogen that the man has. Therefore, it accumulates. When it's accumulated, it's preventing the man to have a proper hair growth, because that's what estrogen will do, and prevent the person to have all sorts of proper ability to function sexually and otherwise. And the breast is likely to be enlarged. The testes will be small and shiny. The penis is going to be short, etc. And all because of the excess estrogen that is circulating in the bloodstream, because the liver cannot handle it. And the woman, she's likely to have hair in her face, right? That's correct. And could have frontal baldness, that's correct, etc. The hair in the face is called hirsutism, etc. So there are many other problems with current breakthrough vaginal bleeding because of the excess estrogen that she carries, testosterone she's carrying an excess, estradiol she carries an excess, etc. Because the liver cannot break these things down. So then she winds up with severe iron deficiency anemia from blood loss. There are many other ways I will get into in subsequent shows that can lead to bleeding, resulting in iron deficiency anemia anyway, but this is just another part of it. Now you want to take a look at the skin, look for swelling. When you examine the abdomen, you have to be sure of two things. Number one, in the beginning of the process of cirrhosis, the liver is enlarged. But toward the end, when somebody has had it for several years, the liver shrunk and is very small. And you can't actually feel it. But in the beginning of the process, the few years before, it is enlarged, you could palpate it. And of course, you palpate the spleen will be enlarged as well. And the reason because the liver causes the cirrhosis causes a condition called portal hypertension. And the portal hypertension occurs because in the substance of the liver, there are lots and lots of vessels that goes through the liver. This is the liver right here. Well, the scarring that's taken place inside the liver because of the cirrhotic process and an inflammatory process that's going along with it causes obstruction of this little vessel. So then there's a backflow of the pressure. And then the back pressure then causes the portal pressure to become elevated. An elevated portal pressure then causes the spleen to become enlarged, which is a major problem that I'll get into when I start to talk about complications of cirrhosis of the liver. Now, to continue with the physical exam, why are you interested in knowing if there's swelling? Well, extremely important, and because when one is cirrhotic, that individual accumulates fluid via two mechanisms, and both mechanisms are working simultaneously. One, of course, the patient has low serum albumin. Low serum albumin because the liver is too sick to metabolize protein properly, so therefore the serum albumin is low. How did this happen? Well, the serum albumin is very important to maintain the integrity of something we call the oncotic pressure. The oncotic pressure is an invisible pressure that keeps one compartment from being affected by another compartment by creating a partition, as it were. So there's the intravascular system, there's the extravascular system, which also call it third space. Now, the serum albumin, because it is normal, it prevents fluid from going back and forth from one compartment to another. See, the body is separated in compartments, and the oncotic pressure is very important in keeping each compartment separate one from the other. Now that the serum albumin is low, fluid is seeping through. So once the fluid leaves the intravascular circulation, it goes into the third space, which is also called the extravascular system. That's fluid, it accumulates. And of course, the tissue gets swollen, the legs are swollen, the abdomen swollen, etc., because of the low serum albumin resulting in low oncotic pressure. That's one mechanism. The second mechanism having to do with the kidney is a substance that is produced in the kidney called aldosterone, which is a natural, normal substance that the liver produces for the benefit of the body. It causes salt to be retained. You say, well, how come something that causes salt retention is good? Well, it's very good because that particular hormone, whenever the body is in trouble, of all the hundreds of stuff the kidney must do to keep the body healthy, one of them, of course, when the kidney senses that the blood pressure is dropping for God knows how many reasons, infection, bleeding, drug interaction, or whatever, the first thing the kidney will do is to clamp down on salt to prevent salt from leaving the body, okay? I mean, by doing so, then fluid is retained as a result of that to keep the pressure head up. You understand that? So that's one of the many things that it doesn't matter how and why one lowers the pressure, so long as if one lowers the pressure artificially, as it were, because if one is treating, let's say, somebody who is hypertensive, and one fails to comprehend how it works, you give people medications, and you're not giving them a thiazide water pill, then of course you might drop the blood pressure because you're giving them such a large quantity of these other medications that can cause hypertension. Yeah, but the key medication is not being given, so therefore the pressure will drop artificially, inappropriately. And then as soon as the kidney senses that happen, then you're defeating the purpose, because the kidney is going to clamp down, hold on to sodium, hold on to water, and the pressure goes right back up. You understand that, okay? And this phenomena is so difficult. Yes, it is so simple for some folks to understand when they're treating folks for blood pressure. Okay, I do not understand it. It is truly amazing. An article, the whole issue of JAMA came out yesterday, and I had my hand on it this morning. I have students in the office right now that I'm teaching. I have no idea whether I'm going to let these students even read that issue, because what's in there is really ugly. It is ugly. I have questioned whether or not I should or should not let the students that I have in my office right now put their hands on that, because the information is terribly ugly, extremely ugly and inappropriate in my view. So the whole concept of how medicine is practiced in this country is discussed in this issue of JAMA that just came out. I just read it while I was having breakfast this morning, and it is ugly. Very important, but it is ugly. The whole issue deals with medical education, which tells you the need that exists for changes to be made is drastic. It's incredible. You have heard me talked about this again and again and again. You thought I was just Valiere Alcena ventilating. No, not at all. I knew what was going on. I say it. I'm an academic teacher. That's what I do. I've devoted 42 years teaching. So I knew what was going on. I knew things were bad, but I didn't know they were that bad. So, I mean, take a look at I'm questioning whether I should or should not let the students take a look at that, because it is brutal. The honesty and the truthfulness that's in the JAMA. I'm sure they'll see it, and I think the right thing to do is let them see it anyway, because it affects them. Okay, so medical students, interns, and residents, it is incredible. In any event, failure to comprehend these things properly is resulting in a whole host of other problems. However, getting back to cirrhosis of the liver, once the liver is sick, it is not capable of handling the aldosterone that is being secreted naturally every day in the bloodstream from the kidney. It happens every day, every moment. And therefore, you have an excess aldosterone developing a condition called secondary hyperaldosteronism. That's correct. Secondary hyperaldosteronism. What that does is that causes a tremendous amount of sodium to be retained in the body, and along with that, water follows. Wherever sodium goes, water will follow. So that's the second mechanism through which inevitably the person is likely to have a swollen abdomen because of something we call ascites, okay? In addition to the low albumin. So now you understand why you might have swelling of the leg, swelling over the tissue, the facial swelling, edema, etc. Now you understand the two classic academic mechanisms that explain why that happened, okay? So because of that, you will pay close attention to that, obviously. Then you will proceed clearly to do rectal examination, because hemorrhoids happens to be very common in people who are cirrhotic. In addition to that, gastrointestinal, upper gastrointestinal bleeding is very common in folks that are cirrhotic. And when I get to talk about complications of cirrhosis of the liver, I will detail all these to you and extensively, so you'll have no problem comprehending them. Therefore, then, you proceed with your physical exam. All aspect of it is very important. And then once you're done with that, now you're going to start an evaluation. Here we go. Okay, so the first thing you will do naturally, you will order a complete blood count. You will order a urine analysis. You will order a complete metabolic profile, also known as a chemistry profile. You will do that. You will definitely order a serum ferritin, because you want to know if the ferritin too high, or is it too low, or is it normal? Very important to know that, because it might be very high because the patient is cirrhotic, or it might be very high because the patient is cirrhotic because he or she has hemochromatosis to begin with, etc. Or it might be very low because of excessive bleeding that has occurred as a complication of the cirrhosis. We don't know, so you do that. Okay, then you will proceed to do a partial thromboplastin time. You proceed to do a prothrombin time. Those are very important, because all these things are made by the liver. All the coagulation factors except factor 8 are made by the liver. Factor 8 is made in the wall of the large vessels in the body. Everything else, all the other factors are made by the liver. So when the liver is very sick, cannot produce these factors. As a matter of fact, the factor that we use throughout the medical field, clinical medicine, to tell how good liver we still have left is the prothrombin time. Of all, it's not the abnormal elevation of the liver function test that I'm going to talk about, because they can be sky high and you might still have some good liver left. However, if the prothrombin time is abnormal and you have no other way to explain that abnormality, then you got yourself major problem, okay? Because then that tells you the factory that's producing the coagulation factor is so sick that it can't do it. You are in trouble. So you see a big setup for major bleeding, okay? All right. So then, of course, now that you've done these things, you're going to proceed to do a complete hepatitis profile. Yes. You do hepatitis A, B, C, D, E. A, less important in cirrhosis because A does not cause chronic liver disease. Okay, so you may choose to do it anyway. So you do the complete profile. That's very important to know whether or not the person has or has not been exposed to hepatitis, because hepatitis is a very common cause of cirrhosis of the liver. And my list is the third one, because obesity is much more common, because you have more people who are obese. 38% of American adults are obese, and 2/3 of population, adult population in this country, are obese slash overweight, and 13% of the children and adolescents also are obese. So it's really very, in this country, of all countries, developed countries, there are more obese folks than any other developed countries, okay? Because of the excess food that we have to eat and the poor quality of the excess food that we have to eat. The system is loaded with junk food, so-called fast food, and people are busy rushing here, rushing there. That's the lifestyle, and they don't have time to prepare a good meal, so they grab a pizza, they grab a hot dog, they grab a hamburger, cheeseburger. There's nothing wrong with these foods if you eat them every now and again, but when you forced by circumstances of life to feast on them, then you really have yourself a potential problem. The reverse happened to me. I was a weightlifter, 240 pounds. I was so poor and then so broke when I came to this country. I lost the weight because I was pretty much starving, having to eat. I have to have $1 per day to travel, 3 separate tokens, 15 cents in those days, and the rest to eat. That was it. Okay, couldn't afford more than $1 a day, all right? And on weekend, I would, when I did get this little paycheck, go to the stores and buy. I don't know if they sell these things anymore. I don't want to be dramatic about it, but I buy the chicken box. They after said that actually they boned whatever left of the good part of the chicken. They was to package those and sell them for cheap, and I would buy those, and those little fine macaroni type thing, very fine little one, and put that together with some black pepper and salt and boil that and put it in my thermos and put it in my valise that I was walking. You'd think I was going to Wall Street with my with suit, and necktie, always all dressed up, and that was it. Okay, so and of course my American cheese and Wonder Bread and my Kool-Aid. I survived that. Okay, but I had so much weight that I could tolerate all that, so I lost a lot of weight because I chose starvation and school over just sitting there and getting $1 per hour and be satisfied with it. So in any event, that was a little. So when I talk about life circumstances, I'm not criticizing anybody. I lived that life. I survived that life. So, but I did not let the life cripple my attitude, my mind, my desire to improve myself. Against all odds, I did. Simple as that. And no other country that I'm aware of in this world would have allowed me the opportunity to achieve what I achieved other than the United States of America. So I'm grateful to this country for what it did for me. So that's why I'm giving in return this big book that I wrote. I didn't write it to make money. Chapter 59 is on cirrhosis, the best of clinical medicine for the 21st century. If it is medicine that you're truly interested in learning, not the nonsense that people are talking about, get your hands on this book. I didn't write it to make money. This is pretty much a gift to the world. And I've given copies to my colleagues and my students and the libraries of the school where I teach, etc. Writing has become my hobby, keeps me grounded at home, and I don't have to be doing anything else. As long as I'm sitting in front of my computer, doing my writing, watching my sport, I'm happy. So in any event, so you proceed with your evaluation by doing all these tests. Those are the laboratory tests. Then what next test you will do beside chest x-ray, of course, would be, you also need to do an EKG, and I'll tell you why in a minute. And then you will, of course, order an ultrasound of the abdomen. The ultrasound will show you the liver, it will show you the gallbladder, it will show you the pancreas. It will outline these things for you. You could do a CAT scan if you want to, but the ultrasound is suffice. Okay, but then there are nowadays all sorts of fancy, incredibly important tests that one can do. And one of the most important tests, of course, is the liver biopsy. Biopsy of the liver. Okay, biopsy of the liver. But you got to be careful. You can't start sticking needle in people's liver without knowing what the prothrombin time is, what the partial thromboplastin time is, and what the platelet is. And all three of these things are likely to be abnormal and cirrhotic. So you got to be very careful before you start sticking needle in someone, and then the next thing you know, they're exsanguinating. So we very carefully do that. And nowadays, with this incredible ability the radiologist has to do in this the little fine needle biopsy, it's easier than in years past. You will have to go to the GI doctor that will then do a liver biopsy with a big needle, etc. So now we just go to the interventional radiologist. They will do a CAT scan. They will be visualizing the CAT scan on the screen, and they have their all incredible ability to put that tiny little needle, because all you need is a little piece, and then that piece will be biopsied and then sent to the pathologist to process in all sorts of different ways to tell you the degree of scarring that exists or doesn't exist, and then you can establish the diagnosis of cirrhosis of the liver by tissue. Okay, very important. And there are other tests that are much more fancy that I've discussed in chapter 59 of this book that are much more up to date that they can do in addition to the looking under the microscope to really nail down the diagnosis of cirrhosis, the degree of inflammation that exists, so on and so forth. And that then they use that to determine the prognosis of this individual, etc. Very, very important. Now, the next part of the discussion, now that we went as far as doing a biopsy, is to tell you what is the meaning of all these tests. What are you looking for? Well, when you do a complete blood count, you're looking at two things, really. First of all, the patient, if the patient have an enlarged spleen, is likely to have what we call pancytopenia, meaning low white count, low red count, and low platelet. Because of the portal hypertension, the spleen is chewing up the platelet, as it were, also chewing up the white blood cell via hemolysis and the white cell as well, to different degrees. So you want to look at those things. So that's very important. And we're talking about someone who may or may not be an alcoholic, because there are many, many, many more conditions that I've listed that can cause cirrhosis besides alcoholism. This individual, you may want to check to see what else is going on with them. Okay, so you look at the indices. Why are you looking at the red blood cell indices? Well, you're looking for macrocytosis as well as a microcytosis. Macrocytosis means large red blood cell, implying that the patient may have low folic acid, which is quite common in alcoholics, and or B12 deficiency, which is quite common in alcoholic because of the pancreatic issues resulting in malabsorption that can cause them to malabsorb, and therefore both low folate and low B12 are reasonably common in these individuals. So you look at in addition to ordering the folate level, which you will do anyway, and ordering the B12 level, which you will naturally do as part of the blood that you send to the laboratory, but looking at the key thing is you have to be very careful, because the MCV might fool you, because if both conditions exist simultaneously, that might cause a normalization of the MCV and the RDW artificially. So you can't just always depend on that. You may have to actually do the level, because when they exist simultaneously, they cancel each other out, and that can create a lot of confusion. But again, this is a level of thinking and clinical know-how that is you don't see every day, but that's what we do. So you look at these things, and then that helps you to know what's been going on with this patient by way of anemia, etc. There's another mechanism through which the red blood cell get damaged. It's something called Z syndrome. People don't talk much about Z syndrome anymore. What Z syndrome is the fact that the liver is so sick. There's a series of abnormal protein, glycoprotein we call them, that the liver usually get rid of. Those are breakdown product of proteins when the liver is processing it. Well, the liver is too sick now. Can't do that. So what happened? The glycoprotein coats the platelet. The glycoprotein coat the red blood cell, and then the spleen read these as foreign substance now, and they just take them out. So that's another way of resulting in hemolytic anemia. So you have the hemolytic anemia that occurs naturally because the spleen is enlarged. Now you have the Z syndrome that is interplaying by the platelets being coated by the excess glycoprotein that's left behind, as well as the excess coating the red blood cell as well. So that's another way that's making it easier for the spleen to sense these things. By the way, it's not just the spleen. All mononuclear cells can become scavengers by taking these normal cells out. Because once they're coated, these mononuclear cells reach them as foreign substance, and that will be taken out. So the anemia, the low platelets, those are multifactorial. There isn't just one thing that can cause them to happen. And you really have to understand, when I talk about complication, the bleeding that occurs, which is the most dangerous part of cirrhosis of the liver, besides liver failure and coma, is the bleeding. And of course, I'll talk to that soon. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.